Hello and welcome. Today we're doing a focus review of Human Immunodeficiency Virus 1, specifically from a Dutch microbiologist's perspective. Now, all the information we're about to cover was compiled using a Gemini deep search, and if you want to dig into the primary sources, you can find a complete list in the Notebook LM document we've linked for you. So we're really going to unpack two big stories that are completely intertwined. First, we'll get into the fundamental virology of this unbelievably complex virus. And second, we'll zero in on the specific, and I have to say highly effective, public health strategies that have been put into action right here in the Netherlands.
All right, let's dive right in by getting to know the virus itself. We'll kick things off with its formal classification, because understanding its family tree is absolutely crucial to grasping why it's such a moving target for diagnostics and, of course, for vaccine development.
Okay, this table really lays out the sheer genetic complexity we're dealing with. We're not just looking at a single static virus. It's more like a rapidly evolving family. And you'll see here, Group M is the big one. It's the main driver of the global pandemic. But what's really wild is how it's constantly reshuffling its own genetic deck, creating these new hybrids, the circulating recombined forms. So what does all that genetic shuffling actually mean for us? Well, this quote just hits the nail on the head. This constant evolution is precisely why a universal vaccine has been so incredibly difficult to create. It also means that for us in the lab, our diagnostic tools, especially our molecular assays, have to be under constant review to make sure we can actually detect this whole ever-expanding constellation of variants. So let's get into the mechanics. How does this virus actually replicate? And maybe more importantly for day-to-day clinical practice, how in the world does it become resistant to the powerful drugs we have in our arsenal? You can really boil the life cycle down to these three critical stages. And each of these stages is where our modern antiretroviral therapies, or ART, jump in to disrupt the process. Each step is driven by a very specific viral enzyme that we can target, and that is the key to understanding how drug resistance eventually pops up. And that leads us to the million-dollar question for anyone managing this infection, right? We know the virus makes a lot of mistakes when it copies itself. So how exactly does it manage to fight back against our best treatments? So here's the crucial point. Resistance isn't some kind of vague, mysterious force. It's all driven by very specific and, frankly, predictable mutations in the viral genes that code for these enzymes. A tiny change, just a single amino acid swap, can change the shape of the enzyme's active site just enough to block our drug from binding to it. This is exactly why genotypic resistance testing is standard practice and so vital before starting any therapy here in the Netherlands. Okay, this brings us to the practical side of things, what we actually do in the lab and the clinic. Let's take a look at how we diagnose and treat the infection, and we'll compare the specific Dutch approach to the broader international standards. For us, as medical microbiologists in the Netherlands, these 3 points are pretty much the cornerstones of our lab work. We use quantitative RT-PCR to see how well treatment is working. And, as I mentioned, we run that critical genotypic resistance test on every single new patient. It ensures we pick the most effective drugs for them right from day one. What's really interesting here is how much alignment there is between our Dutch NVHB guidelines and what international bodies like the WHO and CDC recommend. I mean, you can see a clear global consensus that favors these potent and well-tolerated integrase inhibitors. Where the Dutch approach really shines, though, is its emphasis on single-tablet regimens. It's all about maximizing quality of life and making long-term care as simple as possible. All right, let's zoom out for a minute and look at the bigger public health picture. We're going to dive into the hugely successful Dutch strategy for prevention, and we'll start with the most vulnerable patient population there is. This number, it's just stark. This represents the mortality rate by the age of 2 for infants who get the infection during birth and are left untreated. It's a devastating figure, and it really underscores the absolute time-is-everything urgency of pediatric diagnosis and care. Managing this infection in children is incredibly complex. It's so much more than just shrinking adult treatments down. It demands specialized knowledge of dosing based on weight bands that are constantly changing, navigating all the challenges of drug formulations for tiny infants, and making sure that critical prophylaxis like cotrimoxazole is given to prevent those devastating opportunistic infections. This concept right here, this has been an absolute cornerstone of the modern Dutch response. The undetectable equals untransmittable message, or N equals N, for niet meetbaar, iets overdraftbaar. It was a revolutionary tool, It empowered patients and completely changed our public health approach to prevention. It was a total game changer.
So you see, the Dutch strategy isn't just one single thing. It's this comprehensive, interlocking system. It's smart. It combines early diagnosis with powerful biomedical tools like PrEP and PEP, and it's all built on that foundational principle of treatment as prevention. The whole goal is to shut down every possible route for transmission. And that brings us to our final forward-looking question. We now have the scientific proof. We have the biomedical tools to stop transmission completely. So the next great challenge, it's not really virological anymore, is it? It's logistical. How do we best implement these amazing tools on a global scale to finally bring an end to the epidemic?
We really hope you found this explainer valuable. Please do subscribe for more deep dives on critical topics in medical microbiology. We always love hearing your thoughts and questions, so please leave them for us in the comments below. Thanks for watching.